Ki te rangatira, te mihi karakira, mihi whakatau, ki tēnei ata, te mihi nui kei ki a koe. Hoki tō whānau, tautoko waiata, nā mihi. Hoki raurangatira mā, tēnā koutou katoa. Tēnā koutou katoa. Just by way of context, in my current life at the moment, if you've seen the bio in your handbook, is that I live on Waiheke Island with my wife, and she is also a sufferer, or actually a survivor of breast cancer. And we also live with our grandson, who is now 12, and he's lived with us since he was 6 weeks old. In that whole time of this journey, they have been so supportive. It would not be possible if it wasn't for them. I'd also like to acknowledge, before I get underway, the Prostate Cancer Foundation and Graham for your support, and also the introduction of, particularly knowledge and understanding of where this disease comes from and where it's going to. And Janssen Sealag, who the manufacturers of Antigen, one for making the drug available, because otherwise I don't think I'd be here right now, and two, for their support throughout that process. And finally, I'd like to acknowledge the professional standard and the professionalism of the oncology department and oncologists of the Auckland District Health Board, and one you will be hearing from following me, Dr. Peter Fong. I think without their professional guidance, again, I'm not too sure whether I'd really be here, because I am in an extremely advanced state now, and timing is everything, and timing has been everything in relation to the treatment. So when I was diagnosed, it came in a couple of ways. One you would expect, of course, after the elevated PSA, and then referred for a biopsy and so on. So I just want to talk a little bit about the elevated PSA. I'd had no elevated PSA. I was 59 when I diagnosed, and it came back as 17. When the GP first decided to do the blood test, it was as a result of an accident, which most probably a lot of men have most probably have found their PSA elevated as a result of an accident. And mine was an injury to my foot, and I'd been undergoing intravenous antibiotics for 3 or 4 days, and it appeared not to be working very well. And so the GP decided that he would look at a test for gout, uric acid. And of course, with my knowledge of health, and I said, well, why are you doing that? Because if you look at my history, there's no history of diabetes or anything like this, because I've worked really, really hard on it all my life. And he said, well, he said, you've got gout. And I said, well, is that a question or is that a statement? And he said, well, I think I will. I'll go ahead with the test. And I said, well, if you're going to do that, why don't you do the rest? Because I haven't had a proper test for 3 years. I used to have annual tests because I was a pilot, but I had a 3-year gap. And he said, oh, most probably. I said, well, who's getting paid here, mate? and so that's how they picked up the PSA. The next part was the actual diagnosis of prostate cancer. And I know this might sound bizarre, but when the urologist came out, this was after the biopsy, they sent us an urgent letter that I need to attend a meeting with the urologist post haste and bring my partner with me. So, this sounds pretty drastic. So we go in and we arrive, and we were virtually brought straight in. We didn't have to wait anything. We sat down in this little room, and the urologist came in with a younger person, and introduced this person as the registrar. And he said, the registrar has some things to say to you, and the urologist went out the door. And My wife and I, knowing the system quite well, we're sitting there giggling to ourselves that, oh, this poor thing's going to have to deliver the message, if you like, whatever that message is. And she delivered the message that I had prostate cancer, and she also delivered that it was a high Gleason scale. And it sort of sunk in, but it didn't, because we were still giggling away. And then by the time she'd done that, the urologist came back in, and he came in and started talking about the options forward. When it really struck home was about 3 or 4 weeks later, when I'd been referred by the urologist to radiation oncology, and they had started the process, was that I went to visit my insurance broker, and just by way of query, and I just sat down because we're quite good friends, and I just told him, I said, hey, I've been diagnosed with prostate cancer. He says, oh yeah, and he's sitting there with a piece of paper in his hand just on the other side of the desk there, and he said, what's your Gleason scale? And I told him, and he dropped the piece of paper, and before it hit the deck, he was back in the room with the accountant. And I said, oh gee, this is interesting. And he took the details and said, well, you do realise we need a report from the oncologist and so on. I said, yeah, I understand that. And he said, we'll get the process underway. I said, what process is that? He said, we'll forward pay your life insurance. I said, really? He said, yes, we will. And 2 days after they received the oncologist report, the insurance company wrote out the cheque. That's when it hit home. Because as we know, insurance companies, are not people who write cheques out very easily. And if they do write out a cheque, this is serious stuff. And that's when it really hit home. It hit home so bad that I went through that process as most prostate cancer sufferers and cancer sufferers will go through, as you go through that period of depression and anger and why me and all of those things. And I was lying on the bed feeling sorry for myself at home, and my wife yelled out, it's time for you to take Tane to school, it's your turn today, because I'd been lying there for 2 days. I went, oh, okay, so I got up pretty dishevelled and got in the car and we drove down towards the school. And my grandson was 8 then, and he said, Poppy, he said, when you die, because he was completely up to speed, he said, are you going to be buried in the cemetery? I said, yes, I will be. And he said, oh, that's good, because I can come and say good morning to you every day on my way to school. And I said, oh, the innocence of a child and all of those things. And then on the other side, I hit the brakes and stopped in the middle of the road. And I said, hey! And he said, what? I said, I ain't dead yet. And he said, oh, no. I said, no, it's all right. And that's what started the journey. Because at that particular stage of realisation that this is really, really serious, started the journey of saying, well, how are you going to combat this, if you can combat it, and what are the options? And so I went through a process of treatments, and it started with the Antigen deprivation treatments. And I can remember the first day with the radiation oncologist, because he said, you need to give us consent, you need to make your mind up that you're going to start now, because he said, I don't want to push you too hard, you can go away and think about it, but really we need to get going now. I said, okay, let's get underway. So he said, right, get up on the bed. And so I get up on the bed, and he disappeared out of my peripheral vision. And I could hear all this clunking going on, and I heard something go snick snack. And to me, being an ex-cop, it sounded like the cocking of an Uzi. And I thought, what's he doing there? I said, it's all over right now, And when doctors and nurses draw up injections, you see them draw it up, and you see them at the air out, and they usually come across to you and they give the injection wherever. Well, he came around with this thing around here, still out of my peripheral side. Comes up to the bed, grabs a bit of tuff of my belly fat, and bang! And it was a spring-loaded injection. Well, I nearly went through the roof. Jeez, did it hurt. And he said, well, that's good. He said, now we'll do another one in 3 months. I said, geez, I don't know if I'm coming back for another one of those. And so the process from there was that the PSA was stabilised and then came down, then it started climbing again. And then he recommended the radio-oncologist radiation therapy, so they did on the prostate, and that was for several weeks. And again, still with the Zoladex every 3 months, but it'd be that 3 month injection, as those of you who receive it, has become a wee bit more sophisticated now. It's in a nice little capsule, and if it's done properly, you wouldn't even know you've had it. I think it affects the nurses more than it does you when they bring that big needle around. But then it started climbing again. And I used a couple of analogies in my life, I guess, with the disease itself. It's a bit like a gas barbecue, is that the flame never goes out, and it heats the plate up. And whatever treatments it is, you can pour water on it, if that's a treatment, or you can pour ice or anything on it. The heat will go down on the plate, but it will eventually come back up again. And that's sort of been the journey. The other analogy I use, and I often use it on my poor oncologists when we're consulting, because I use military or war tactic analogies, is that I've been wounded, but I can still fire a rifle and I can still drive a tank. I've got to a point now, though, that I'm not so sure if I can push the clutch in on the tank now, because there are some side effects now that are starting to kick in, which has compromised my core strength. The next journey was chemotherapy, and it was docetaxel. And fortunately for me, I've been on this line where new treatments have just been approved by Pharmac, and docetaxel, of course, was approved in 2011, and I went on it in 2013 for 6 months, and that had a good effect. And then through all of this time, I continued working. I never took a day off for any of this, not even when I was on chemotherapy, much to the dismay of some of my work colleagues, because sometimes after being at chemotherapy, I was pretty white, sort of a Māori going back to work, and I'd go back into work and they'd be more concerned than I was about what it was. Then the discussions with my oncologists were simply this, that at that period in time, once we got beyond docetaxel, there were no options, or very little. And it was hard to strategise, because when you think about your family and you think about the things that you do and the commitments that you have, like all of us, you think, oof, how are we going to manage? And there are always a few tearful times. There's times where there are depression and so on, but there's understandable depression, of course. And so we moved on. But in part way, about 2/3 of the way through the chemotherapy, came a word that became a bit of a gem to me. It was called Zytiga. And of course, at that point in time, it had only been approved by MedSafe, and it had gone into Pharmac for its approval. And it kept dragging on and dragging on and dragging on. And so I started privately. And so each prescription of Zytiga after the chemotherapy was $5,000 a prescription. And still the approvals for Pharmac just went on, and as you all now know, it was approved in May for introduction as of May this year. My wife and I had a bit of a standing joke about Zytiga and saying, well, it'll take so flippin' long that I'll be on my last 3 days in hospice, and you're lying there and there's, it's just about time to go. And a courier will come in with a little package for Mr. Wikaira. But it gave me a quality of life that I don't think I fully understood until now, and how much quality of life that drug was able to give me for just over a year. I was able to operate normally, work, play, socialise, everything that you would normally do as a person of my age or younger, because I was back out paddleboarding and doing all of those sorts of things that I used to do. And it worked so very well. The only side effects that I had was fluid retention, which I carried a bit of weight, and if you look at some of the previous photos, you will notice it, because you had to take it with other drugs, and I'd like to thank them for saving me a lot of money on cosmetics, because when they puff your face up, you don't see the wrinkles. Earlier this year, what happened was my creatinine levels started climbing, which is an indicator that your kidneys are starting to get into trouble. And after X-rays and ultrasounds, they discovered that my left ureter was being blocked by the tumours. And I was referred to urology for an option. And here is another interesting part of your journey, and this is about interspeciality referrals. So you're being referred to urology, so you go out of the hands of oncology, if you like, for an option. And here I was lying on the hospital bed, and I saw this young man come striding down the corridor about 10 o'clock in the morning, and I thought, he's the urology registrar. And he was still 20 metres away. And I could also tell by his body language that he had a predetermined text, and there was not going to be any variation on that text. And so he walked up after he'd introduced himself and identified myself as well as the patient. He said, okay, now the options are simply this. If we do nothing, you'll be dead in 3 weeks. And I said, well, yeah, look, I know that, and I understand that, but I'm not ready for that yet. If I was, I'd say, leave it. And what's the other option? He said, nephrostomy tube for the rest of your life. I said, for the rest of my life, not just as an acute option for this time. He said, no, for the rest of your life. Okay, well, within minutes I was wheeled off and in it went. And I went home. Well, I don't know about any other people that are here and whether you've ever had a nephrostomy tube outside of a hospital setting. But when you go home, it's almost impossible to manage, because people are walking past you, you can knock it, you can, on the fridge door, pets going past, jumping up on you, getting in and out of cars, all those sorts of things. So, guess what? 3 weeks later, I'm back in hospital again. In fact, I'm back in ED with renal toxic shock, because the thing had moved and leaked. And as a result, I was admitted to ICU for several days for treatment. And the interesting thing about ICU, as you'll see in my bio, I was the CEO of Westpac Rescue Helicopters. I know most of them because I used to fly them on the helicopters. And but again, this is another question about interspeciality referrals, because in some respects, from a patient's perspective, you tend to understand that if you are a strong patient, if you have quite a lot of leeway left, and what I mean by that is a lot of life and a lot of ability to be able to continue your survival, that the interspeciality referrals should reflect that. I'm not so sure when some of those referrals happen, particularly with urology, because there's a threshold. I mean, let's be frank, if I was in my last 2 months, they wouldn't refer me to ICU. And I'd understand that, because you're taking up a whole resource, a huge resource, and your likelihood of survival is not that great. And in fact, it won't be great at all. But when you're at the lower end of or the middle end of the threshold, if you like, it's that question around, do they take you or do they not? And that's still a question that's still hovering around. Now, I've talked to this to my oncologist, and he's assured me that, yes, we do, that this is always in mind, but, when we do the referral, it depends on the outcome of the patient. Just because often when you're referring, the good thing about oncology is that you have a very clear relationship with your oncologist and the oncology department, which you do, and that's a real key. But when you're going into another speciality, they don't know you at all. It's just lucky that in ICU I knew all those intensivists. But that wasn't the criteria that they used to get me in there anyhow. So it's just something that I would note. What's the result? Well, I reckon that whole episode set me back about 6 months, because I've lost all my core strength, I've got a lot of side effect that's come from it, and so on. What has been the lifestyle to all of this? Well, if we talk about, and we heard our first speakers talk about sexual function, well, that was one of the, when I was diagnosed, I didn't have any symptoms. I didn't know that I had prostate cancer. Even when I was told they had it, I thought, well, no symptoms, no pain, no urinary problems and so on. But there was one. It was sexual dysfunction. I noted, as in retrospect, that it started to go down, literally. And then when I started with that first Zoladex injection, it then became a historical fact. And so there is no sexual function. There has been none since 2009. And of course, with hardly any testosterone in your body, I'm one of the safest male drivers on the road. So the treatments that are available now, I'm now on enzalutamide, which is a drug which is a drug that succeeds, if you like, Zytiga, and its side effects are a little bit more vicious than what Zytiga was. But nevertheless, we're in the early stages of seeing how that goes. I'm so glad I'm not paying for this one. It's about $90,000 a year. And it's only at MedSafe at the moment. I don't think it's even got onto Pharmac yet for its initial application. So it's a little way off. But what I can say, it's so very exciting to hear and see what is available and the options that are coming up around the world as well as in New Zealand. And my last bit is simply this. As a result of what happened to me at my diagnosis with the GP, I've changed my GP. And I travel from Waiheke Island to West Auckland to my GP. Why? Because I have a relationship with the practice, not just the GP, the practice, the doctors, the nurses, the reception people. That is a relationship that they understand what you are about and who you are and what are the things that you may need, and vice versa. One of the things that I would really, really like to say to primary health care, and some might say because of all of these inequities that we all talked about, and you've heard some of it this morning, and you'll see it in Dr. Lawrenson's research about inequities and lack of access and Māori health, Māori men and Pacific men, simply this. What it tells you by definition that there is no relationship. Right? There's no relationship on the primary healthcare side, and there's no relationship on the patient or whānau side. And so one's getting paid to have that relationship, and the other one is out there. Now we all know, we've all heard the discussion this morning about men and men, and so on. But the reality is, primary healthcare, you've got to get out of that 15-minute scenario, and you've got to have that relationship with your men. And part of that chart, if you like, or guidance that you saw this morning, that's what it's about. It's about discussion. It's not necessarily about testing straight away or anything. It's about having a discussion and the relationship. I think I'll end it there because I think the bell's going to ring again. But thank you very much for listening this morning, and hopefully I'd like to see you all again next year. Kia ora.